talk and your groundbreaking work in Pakistan. Next, we are in for a talk by Dr. Sriram Lyer. He'll be joining us from UK on Zoom. He's renowned for his work in sleep. His research and his innovative methods have earned him fame and name. Let's please welcome Dr. Sriram Lyer from Sheffield Hospital, UK. Dr. Sriram, the stage is all yours. Thank you very much.
Thank you so much. Good morning to you all, or good afternoon to you all. Just checking that you can hear me all right. Okay. I'm just going to try and share my screen.
He'll be talking to us about newer concepts in sleep-related breathing disorders.
I'm hoping you can see that. Just to let me know if you can't. Thank you so much.
Yes, we can.
Particularly grateful to Dr. Murtaza Kazmi for the invite. So, great pleasure to be here. So I'm a sleep physician. I work in Sheffield, which is as most of you are probably aware, it's a city in South Yorkshire. We have one of the largest sleep centres in the north of England. So I do both respiratory and neurology sleep. And my focus today was on neurodiagnostics in OSA, and specifically it was to talk about what was new in the field, any updates on treatment and how we approach OSA in the modern era. So I'm going to try and restrict myself to this. I'm conscious of time, so I have got a couple of slides and I'll move on. I think I'm running late. If I have time, I'm hoping to cover approaching excessive daytime sleepiness in OSA as well. So you don't need me to tell you that OSA is an epidemic. So this is data from a few years ago, the expected incidence of OSA around the world, and you can see that in Pakistan, for example, the number of patients with at least moderate sleep apnea is in excess of 17 million. And like all other countries, the majority of these will be undiagnosed. So when you're faced with such volumes, the concept of having a polysonogram, the gold standard test for each and every patient, I think is unrealistic. It's fair to say. Yes, it is a gold standard, but it's also uncomfortable. It involves usually an overnight hospital stay, and there is a so-called first-night effect from all of the equipment that patients wear. It's expensive, both from the point of view of the physician time as well as in terms of costs. So we, at least in the UK and probably in some parts of Europe and a large part of America, have moved away from PhD for every single suspected sleep apnea patient and been increasingly using what we typically call home sleep apnea studies, which are these level 3 limited chance studies. In the UK, I would say this is probably 95% of the time we use them as the first diagnostic test of choice. Typically, as you all know, it has a number of different channels. Some channels are optional and what I call enhanced, for example, video or limb movement leads, but the majority of channels will encompass all of the respiratory components that you require to make a diagnosis. I want to touch on a couple of devices that are quite popular, both again in Europe and America. This, if you're aware, is a watch track device. So it works on the premise that every apnea or hypopnea event is followed by an autonomic response, which is visual restriction and tachycardia. So the device actually measures, in addition to oximetry, your autonomic response following an apneic event. This is a sample, sort of a snapshot. So you can see that as there is an apneic event happening, there's visual restriction. So that visual restriction is picked up and there is concomitant tachycardia. So it's a surrogate marker. You're not really picking up the actual event, you're picking up what happens after an apneic or hypopneic event. And this has been validated against PhD and is moderately sensitive to picking up sleep apnea. The company insists that they can also reasonably accurately stage sleep I think there's a little bit of controversy around this, but it is being used as a first-line test for ruling in or ruling out sleep apnea in several centers around the UK. This is a night-owl device, very similar, just a smaller form factor. This company is now taking over Resonate, so you're probably unlikely to see it in use for the foreseeable future. This is an acutable sensor. Again, some of you will be familiar with this. It has a presence in Europe and in America at the moment. I don't know if it's made its way to Asia. So this is an acoustic sensor and sits on effectively on the trachea. This is also been validated against a home sleep apnea study, not against a PhD, and it is reasonably accurate at picking up sleep apnea. So it's currently being used as a rule-in or rule-out test in many centers around the country. And I guess the difference with these two surrogate markers is that they have a small form factor, so patients find it quite easy to use. And especially during the pandemic, when we had issues with equipment being cleaned, they represented reasonable one-test options. This is a standardized device. Now, again, this is being used variably across Europe and America. This works on the premise that there is an intimate relationship between the motor trigeminal nerve, which attaches to many of the pharyngeal muscles, and the respiratory center in the brain. And again, this is a surrogate marker, so it uses the mandibular movements and these pharyngeal muscles as a surrogate marker for respiratory events. So I'm not going to go into great detail, other than to show you a typical trace where there is absence of airflow, and you can see that that is reflected in the absence of mandibular movements. So again, it has been validated against PhD, particularly from the French group, and there is, as far as the group is concerned, growing evidence suggests that you can use these mandibular movements to create sleep staging as well and detect arousals. I can't ignore smartphone apps. These are in wide use in the UK. I think a lot of patients in my practice who have used a snoring app or in inverted commas sleep apnea app, telling them they have sleep apnea. There's one app from Australia called Rest app, which ran a feasibility study of 700 odd patients and compared them against polysomnogram. But again, impressive sensitivity and specificity when you consider this is a smartphone app. So it is something that you probably have to consider, especially in resource-limited settings, if people come to you with these app results. Consumer sleep trackers. Again, I have patients who use all manner of sleep trackers or smartwatches. They very cleverly place themselves in the wellness sector and not in the medical sector, so they're not medical devices that are approved. They have no regulatory approval. I don't know what algorithms they use. They are sort of black box algorithms. But you're going to have patients who come to you with abnormalities, and I think given the technology that goes into these sensors, if you've got somebody with valid symptoms and an app that tells you that they've got potential sleep disorder breathing, you're obliged to investigate. So that's a brief business talk tour of sleep apnea diagnostics. I thought I'd touch a little bit on what metrics we use in making a diagnosis of mild, moderate, severe sleep apnea. And traditionally, as you all know, we've always used the apnea-hypopnea index as the one metric that dictates everything from diagnosis to what treatment you offer. It is now increasingly being believed that this is perhaps not the ideal metric for the purposes of decision making. I've given you a hypothetical example here of a patient with severe sleep apnea, with the AHR 36. The graph at the top shows you that there is no time spent below 90% at all for this particular patient. And patient B has spent quite a lot of time with deep desaturation below 90%. So the idea is that if you use the AHR alone, you're not going to capture the nuances of patient A and patient B. And patient B clearly looks to be at high risk of both symptoms and long-term complications. So we should be using a lot more of the metrics we get from our sleep studies to find risk stratifications. There's a lot of work that's been done on this. This is the ELS task force that was set up about 6 years ago to examine all of the evidence in terms of how patients present with symptoms as well as the sequelae of sleep apnea. And you can see here that there's a proposed matrix where you divide people into sort of 4 rough categories. Those on the left end of the scale, for example, patient A here has mild symptoms and has minor end-organ impact, so not a lot of complications. And at the other end of the spectrum, you've got somebody with severe symptoms, along with a lot of other comorbidities. So clearly there will be patients between A and D who either have lots of symptoms or who have a lot of comorbidities but less symptoms. So I think it's important to be conscious of not using just one metric to base your treatment options on. This is sort of again a European study looking at cluster analysis, looking at the phenotypes of patients that present with sleep apnea. And you can see there is a phenotype here, for example, that mainly complain of disturbed sleep. This is particularly true of females. And you've got some that are minimally symptomatic, even if they have a lot of disease. And then you've got a combination of people who are either very sleepy or who have a lot of upper airway symptoms with very little sleepiness. Again, I'm just showing you a cluster of 5 different clusters of patients with different phenotypes. And not all of them should be managed into either CPAP or lifestyle management. There does need to be some thought into how you individually stratify these patients. That moves me on very nicely to endotypes. So when we talk about pathophysiology of sleep apnea, we generally talk about 4 different categories of patients. And there may be patients that have all 4 pathophysiologies. But you're either talking about people with impaired pharyngeal anatomy, where the palate muscles aren't working very well, or you're talking about patients with a very collapsible upper airway. You're either talking then about patients with a very low arousal threshold, so people who wake up quite easily, and that causes sleep fragmentation. And then you've got patients with a very high loop gain and an unstable respiratory control, where you have an exaggerated response to an apnea. So in variable amounts, you're going to find this pathophysiology combination of this in the sleep apnea patients. And the argument is that you have to treat them differently and manage them differently. I don't expect you to sort of look at this and absorb it here, but it's just to say, if you look at the clinical phenotypes on the left and the pathophysiological phenotypes on the right, you're going to have a whole subcategory of patients with different phenotypes and endotypes. And they're all going to have different treatment options that might work better for them. So it is really important that you try and customize your treatment as much as possible. So non-CPAP therapies. Again, I don't know how much these are taken off in Pakistan. So we're kind of slowly moving away from CPAP being the primary modality of treatment for sleep apnea, simply because of issues with compliance. I'm sure issues with costs as well in other countries. And there is increasing evidence now that there are other treatment modalities that are probably going to be equally effective, if not more effective, for some categories of patients. This is the mandibular advancement device. All of you will be familiar with one. There has been a lot of recent research in mandibular advancement devices. It is now on our NICE recommendation that patients with CPAP intolerance or even symptomatic patients should be offered a choice of either CPAP or a mandibular advancement device, especially in mild and moderate cases. This is a meta-analysis of RCTs, and you can see here that the bottom line is MADs and CPAP reduce effort scores in a very similar fashion, with no real superiority of one over the other. And the argument will always be that we consider treatment efficacy. Efficacy is a product of both compliance and efficiency. And if you have better compliance with an MAD, even if the efficiency is low, the overall efficacy is probably comparable because people are more likely to use an MAD more than CPAP in some cases. So it's certainly something worth considering, and treatment pathways, at least in the UK, are probably going to change in the next year or two to encompass non-CPAP options. A couple of other things. So this is, I just picked this up off the internet yesterday. So there's a trial called the COSA trial, which is the position OSA trial, and the results are still yet to be published. But effectively, if you've got an AHI that's particularly worse than supine, you have position sleep apnea, and there are these positional devices, both commercial and medical, that you can purchase, which are probably cheaper and in some cases more likely to be used by patients. They can be quite effective as long as you select your patient very carefully. So this is the hypoglossal nerve stimulator. So the idea is that you have a sensing electrode placed implanted underneath the chest that detects chest movements, and you've got a hypoglossal nerve stimulator. So this is like a pacemaker that just sits underneath your chest, implanted underneath your chest. And we had our first patient treated last year. So this is again for CPAP intolerant moderate OSA patients. And the initial results are promising, although watch this space because we don't know the long-term efficacy or the side effects from this group of patients. But it is something that's again on the horizon that's likely to be part of regular clinical practice in the future. I'm not going to discuss drugs because I don't use drugs for OSA patients in my practice. So I don't know nobody in the UK uses drugs, be it sort of theophylline or acetazolamide. The only promising drug on the horizon is a atomoxetine oxybutyrate, so anticholinergic norepinephrine uptake inhibitor combination that has a direct action on pharyngeal muscles. And there's one RCT showing some benefits that it reduces AHI, but again, this is early stages, and you're probably talking 2-3 years before we know more. Okay, so I think I've got some time to talk about excessive sleepiness. So we all have a cohort of patients who have sleep apnea that you're treated, who then continue to remain symptomatic despite compliance to treatment. And I thought I should focus my attention on these patients because a lot of them take up sleep space. The majority of sleep space consumed by looking after these sorts of patients. So I think we should start with the definition of what excessive sleepiness is because it is quite prone to misinterpretation. So we're talking about the inability to stay awake and alert during the major waking episodes of the day. Okay, we're not talking about excessive sleepiness at night, we're not talking about fatigue, we're not talking about tiredness. Sleepiness obviously can vary in severity and if it's situation specific, so you've got to be mindful of that when you get a careful history from your patients. So when we look at the literature, the incidence of excessive sleepiness in OSA is widely varied. I mean, you go anywhere from 9% and some cohorts up to 60%. Okay, so but there is the important thing here is that there are going to be people who are still going to be sleeping after you've treated the sleep apnea. And if I take you back to the original clinical phenotype that I showed you of the people with disturbed sleep, the ones that are mainly symptomatic, and those excessive daytime sleepiness, you can see there's a lot of overlap here. There are different people with different clusters of symptoms. Some will have more sleepiness, some will have more disturbed sleep. So again, to a large extent, the effect of the treatment depends on their symptoms before you start the treatment, so to speak. And the problem with recognizing sleepiness is, as I've said, it can get misconstrued with tiredness or fatigue or brain fog or lack of energy, any number of terms that people use. Symptoms can overlap with other medical conditions, particularly mental health disorders, or people with obesity, people with diabetes, chronic fatigue syndrome, and so on and so forth. And as I said, it can be quite situation specific. If you ask somebody who has not slept because they're having university exams for a couple of days, they are going to be more sleepy compared to somebody else who has a different lifestyle. We also use the Epworth score, like the AHI, as an all-encompassing score that should exactly tell the state of health or state of sleepiness of the person. It has got its inherent flaws. This is a random distribution of Epworth scores in the community with no formal diagnosis of sleep sleep apnea, and you can see here that it is a bell-shaped curve with sort of extremes on either end. And there are people who have no diagnosis of sleep disorder breathing who have abnormal Epworth scores. And this is Epworth scores taken in people on CPAP, again in the community, and again you can see there's a lot of people here who still complain of sleepiness despite not diagnosed with sleep apnea or not on CPAP. The sleepiness scale in medical conditions, so just to give you a few examples here, I'm not able to, this is diabetes, malignancy, obesity, and the baseline Epworth score in a lot of these patients is quite elevated. Okay, so it may be that you have incidentally picked up sleep apnea in somebody who's sleepy, and the sleep apnea maybe has not had an impact on the sleepiness in the first instance at all. I'm not going to discuss too much of objective measures. They are time-consuming. They can be used in specific populations. They can be quite useful. But mass testing in terms of testing every single patient with sleepiness with an MWD or MSLT is not practical. This is simply a graph to show you that anesthesia residents, this is a study from 30 years ago, I found it really interesting that anesthesia residents had an abnormal MSLT at the time. So it's not something that you can use widely and say this is accurate. So if you genuinely look at high quality papers that have looked at excessive sleepiness with OSA, you are talking about an incidence of between 6 and 20%, okay, of people where you have excluded everything, the proportion of people who are going to be sleepy after treatment. And there have been many mechanisms that have been postulated. So one theory is that people with sleep apnea have long-term intermittent hypoxia causing damage to the weight centers, and there is some neuronal loss associated with sleep fragmentation at a chronic level. And these are also PhDs, papers that have been published looking at this. But excessive daytime sleepiness has been shown not to be related necessarily to the severity of OSA. So that puts that theory under a bit of a cloud. The duration of the damage is unknown in most cases when you see patients. So I think it's difficult to draw definitive conclusions on why some people are more sleepy than others. This was a meta-analysis of a large number of patients who were followed up with and without excessive daytime sleepiness on CPAP. And I just want to highlight that if you are a slightly younger cohort, you have a high BMI, you've got more severe AHI at presentation, and you have a higher Epworth score, then you're more likely to have persistent sleepiness after treatment. So my general approach to this is outlined here. I don't think I have time to go into detail in any of this, but effectively you're going to have to look at their sleep history, you're going to have to look at whether their OSA has been truly treated, and you've got to look at other sleep disorders or other medical/mental health conditions, and you've got to address each and every one of them. So I'm going to skip a few slides in the interest of time and move on to drugs for excessive daytime sleepiness. The most commonly used drug for many years for this cohort, whether you call it residual excessive daytime sleepiness or idiopathic hypersomnolence in people who have OSA, was modafinil and armodafinil. And if you look at the evidence, there is moderate quality evidence that using either of these drugs gives you reduction in the Epworth score and increased wakefulness if you objectively measure it. And the number needed to treat is about three patients to get benefit to one patient. There are side effects. 20% of patients with modafinil will have a headache that can be quite debilitating, and therefore long-term compliance is a bit of a question mark. Again, it comes down to patient selection, and it comes down to how thoroughly you have vetted these patients for other conditions causing sleepiness. If their sleepiness is multifactorial, then modafinil is less likely to be effective. The only thing I'll say is that all of these studies using modafinil or armodafinil, they've always been compared against placebo and not against. A couple of other drugs that I think will be useful and important in the future: Sriram Lyer and tolosat. So Sriram is a dopamine reuptake inhibitor. The mechanism of action in maintaining wakefulness is not really very well understood, but this is the TONES-3 trial from a few years ago, where patients received increasing doses of solriamfetol versus placebo, and you can see here that they had a better MWT score, they had a better effort score. This was at 12 weeks. I've seen more data now recently suggest that this has been sustained at 12 months with no major side effects. The only thing I will say, which might be relevant for an Asian population, is that it does cause a slight increase in the heart rate, and it does slightly increase the blood pressure. Modest increase in blood pressure by a few millimeters of mercury, so that's important to take into consideration. And the treatment effects are similar for patients with OSA, whether they're adherent to CPAP or not. And as I said, 67% had some adverse events, but interestingly, the placebo side effect was 47%, which is always interesting to see. So pitolisant is an inverse H3 histamine receptor antagonist. Again, the mechanism of action is unclear, but this was the HEROSA-1 and HEROSA-2 trials, which were good quality trials, and again showed that your effort score came down and was sustained at 12 weeks by 6 points, which is quite significant. And again, this is the same for people who had refused CPAP with sleep apnea. So even if you have sleep apnea, you don't use CPAP, you are sort of more likely to benefit from pitolisant. These drugs at the moment are expensive. They are only used in narcolepsy, for which we have a nice mandate in the UK, but they're likely to come down, the costs are likely to come down in the future. So it's certainly something worth considering for your sleepy patients in the future. So, in summary, I think the diagnostic landscape of OSA is changing. You're going to have to be more personalized with your OSA care and not just simply assume that the AHI is the one single metric or CPAP is the only modality of treatment. You will have to look at endotypes and phenotypes if you want to improve treatment efficacy and customize treatment for your patients. And I think non-CPAP modalities are increasingly going to play a role when you consider treatment options. Important to consider the causes of residual daytime sleepiness in your OSA cohort, and these patients need careful assessment as sleepiness could be multifactorial. The effort score is still the most widely used tool, but you need to be aware of the limitations and apply it wisely. And as I said, I think you need to be systematic about how you assess your OSA and your excessive daytime sleepiness patients. So I'll stop there. Sorry, I overran by a minute.
Thank you so much, Dr. Iyer, for such an informative and insightful presentation on sleep apnea, such a common problem. We really appreciate it. Thank you. Now next, move on to Dr. Naveed Mustafa. He's a respiratory consultant in North Midlands, UK, and he specializes in home ventilation and weaning. He's leading that unit there, and he's also the director of Motor Neuron Disease Care Center. So let's see what he has in store for us. It is Dr. Naveed Mustafa, you have been with us for some time. Thank you for your patience.
Can you all hear me?
Yes, we can, Doctor.
Okay, great. I'll just get my slides up.
He joined us even when we were not in the hall. It's kind of embarrassing.
Okay, yeah, my slides up. Okay. Yeah, so thank you very much for asking me to speak, and thank you very much to Dr. Kazmi, who has worked with us previously, and I'm very grateful. Sad that I'm not able to attend in person, so I do apologise for that. And unfortunately I'm on call today, so after my talk I may not be able to attend the questions and answer session, but I can take, if you can let Dr. Carlson know, I'll be happy to take the questions afterwards. I've got nothing to declare. So, respiratory muscle weakness is something that we commonly come across, and it's usually when neurologists refer patients to us who develop respiratory symptoms. But just always need to be aware that actually it may well be that a respiratory muscle weakness can be present in diagnosis with often associated with the late breach, but it can actually be a very early breach. And in fact, there may be respiratory muscle weakness may well be the presentation of neuromuscular disease itself. When we get a patient presenting with those sleep symptoms and the neurology diagnosis afterwards. It's happening respiratory muscle weakness is progressive, and in neuromuscular disease patients, the symptoms that they get are much more subtle and insidious compared with respiratory diseases because their activity level due to lipids goes down, is reduced, and then we don't have the luxury of having exercise challenges on these patients to get the symptoms early. And the symptoms are also, because they're a bit different, they have multiple causes. So the same symptoms such as sleep disturbance may not be related to respiratory. There are other reasons as well. So it does become a bit more complex. The importance is that in all neurological conditions, the commonest cause of death
this just adds to the complexity that I'm afraid we have with neuromuscular disease. And patients will present with the classical teaching is that we get diaphragmatic weakness of inspiration, which leads to hypoventilation, to reduced ventilation, breathlessness on exertion, and starts to eventually their sleep. But in addition, they can get weakness in their abdominal muscles, which are their cough muscle, which leads to a reduction in cough, leads to difficulty with clearing sputum, and makes them more prone to asthma. And it's complicated even further because they also can develop bulbar weakness, so facial muscle weakness causes a weakness in their cough, increases aspiration as well. It leads to multiple number of symptoms. And even the treatments, so for example, gastrostomies, people have significant bulbar weakness, are the ability to put a gastrostomy is affected by how good some of the muscles are. So I've divided up the talk into inspiratory muscle weakness, so inspiratory failure, cough failure, and swallowing failure. Just three sections that we'll deal with, and it's just an easy way of approaching the patient with neuromuscular disease. So in respiratory muscles, the normal respiratory muscle, the way to look at ventilation is to think of the respiratory muscle adequate capacity, more than adequate capacity to deal with any respiratory load that you place on the respiratory system, so your ventilation is adequate. The respiratory pump, however, can run into trouble. Classically, things that you've already been talking about on critical care, the majority of cases, things like which lead to people needing ECMOs, are increasing the load on the respiratory system. This can be any respiratory condition, so it can be a person's got ventilation diffusion mismatch, pneumonia, PE, diffusion impairment, then pneumonia, pulmonary edema, interstitial lung disease, or shunt. These are all things that you have to compensate for. And eventually, patients initially just need oxygen because the capacity to keep ventilation adequate, but eventually the load can increase so much that it overwhelms the normal respiratory capacity that the person has. The pump capacity, and they enter into failure, and that's when the care colleagues to help out, and this is what the earlier talks have been, is that you support the person, let the load reduce and the person improve. Other things that cause the load to go up are airways obstruction, changes in the compliance of the lung, when a person is supine, diaphragm working against gravity rather than with gravity, that increases respiratory load as well, hypothesis, obesity. So all these things increase the load of respiratory. In neuromuscular disease, you have a reduction in capacity, you get neuromuscular weakness, you get diaphragmatic weakness and reduction in capacity, and you also have reduction in capacity in REM-related rapid sleep, because that's when you're dreaming, and that's when your accessory muscles, you only have your eye muscles left open working, and you only have your diaphragm working. And so if the diaphragm is weak, may not be able to manage, and that's when you have problems. So you can see that you can think of a patient when they present to the clinic, and the normal circumstances, person if they are able to exert themselves or get references to exertion, this may not be available to us if they are limited physically. They can develop, as I said, difficulties in REM-related sleep, and this is when they might start to recollect their dreams because they've been saturating when they wake up, and they get nightmares. Eventually the sleep is interrupted further and further. They will tell you about sleep fragmentation, they'll tell you about waking up not refreshed. And one of the things that all registrars and registrars ask them to say is the headaches in the morning, which they'll say is due to, and the textbook say is due to hypercapnia relatively overnight, but actually you get headache in the morning because you don't have adequate sleep. And the younger ones who are still doing on-calls overnight will know that when your sleep is interrupted, you won't wake up after a shift, but you haven't had enough sleep, you get a headache in the morning. And it's not because working and it's interesting because you heard the study about anesthesia residents. It's not something that they become hypercapnic overnight by working in anaesthetics. It's because they've not slept well. That leads to headache. And eventually you start to sleep. Your concentration goes, and then you start falling asleep inappropriately. And eventually if you push a muscle so weak that the person is not compatible with life. And underlined appetite, and the reason I underline appetite is that people can get appetite reduction is actually a consequence of restrictions, sleep sleep, not just other causes of neuromuscular diseases. It's important to remember that this may be one of the few symptoms, and lastly, symptoms may actually be absent. Signs are often absent. You may see the person having shallow, not breathing very much, they may be a bit sneezing, or breathing, or they may have an increased respiratory rate. The usual things you see with people with respiratory condition. Abdominal paradox is when you put your hand, and there's again, I'm not there, so I can't show you, but you put your hand on your chest and one on your abdomen, you have a big sniff. Both your hands will move outwards. In abdominal paradox, because you've created negative pressure in your chest, and the diaphragm is weak, it's called, you can't compartmentalize, and the abdomen gets sucked in, and that's called abdominal paradox. If any of you did that yourselves in the hall, and you witnessed abdominal paradox, get on to Dr. Carsky and you can contact me, and I'll speak to you later. So how do we assess respiratory muscles? And most of the techniques that are used, and again with the sleep study, we've had about some things that which are just simply not practical that can be done. I'm just going to touch upon them just so that people are aware. And I'll talk about the tests the non-invasive tests, which we are all have traditionally to do. So non-invasive tests, vital capacity is a very good, repeatable and serial test that can be done and it's widely available. The disadvantage with it is that you can have, it's not very sensitive, and you can have a very good and significant hypercapnia, shown quite much better. So it has its limitations. Mouth pressure is a much more direct measure. Muscle strength is a much more direct measure of tension that you can create. But you need, for mouth pressure, you need to have a good mouth seal, and we've just talked about people having difficulty achieving a good mouth seal because of the weakness of facial muscle weakness. There's my colleague at the bottom he's doing this inflammation and respiratory pressure thing in his nose there, and he's got sniff is a much more natural manoeuvre, and if people are able to do it, it's quite repeatable. So there are a number of tests, and I urge you to use all of them. Vital capacity improves if we do supine vital capacity. You would expect to fall less than 20% in normal individuals. If it's more than that, then it suggests that weakness. But there is a practical issue there, although the equipment is available in clinic to repeatedly do supine vital capacity. That's just me in years gone by, just to demonstrate that it's a very practical test to do. This is just a graph I wanted to show you, vital capacity against stimulation and respiratory pressure, and hopefully it shows that you can see that there's a cut-off at around 30 to 40 centimetres of water for predicting sniff, which is you can be confident the person doesn't have hypercapnia. But in patients with vital capacity, you can see the spread is quite mixed. So it is a more difficult test to predict restrictions and weakness. So invasive tests do improve sensitivity, and I'll show you why. And they're more direct measure of gastric and esophageal pressures, but you need to put nasogastric tubes. And when you put them in, this is the sort of measurements you get. You get abdominal pressure, esophageal pressure, and a PVI, transdiaphragmatic pressure. And you can see the significant red reflecting negative pressure here with positive diaphragm, and that tells you if you good transdiaphragmatic pressure on the person with a normal test, and then on the other side you've got the person with a parallel. Can you see the negative pressure as a result of now that you're measuring esophageal and gastric pressures, you can stimulate the nerve, and you can do it magnetically or electrically. I've had this done to myself. It's actually it's comfortable, it really doesn't hurt, and you measure the pressure generated. Here you can see comparison of two cases, so two people, one with a normal pressure on very low stimulation, and one with weakness. The advantage of the technique is in the operator, not in the machine. Other than the simple oxygen saturation of blood masses, the oxygen saturation is low. Overnight oximetry, the discussion then, the traces are, which is sort of true that the massive variability between happening, but you start off with getting red and the oxygen saturation, and then progressively decreases down. Now the other thing with sleep is this, once it's disturbed in situ, often known as people stop going into stop sleeping. So you just need to don't be mistaken by early activity if the only test managing respiratory muscle weakness, first of all, is monitoring, and I would suggest that you do as many tests as you possibly can. Eventually, some tests will be less helpful, so somebody may be not very good at one particular test and that becomes apparent, and then may not be worth repeating. But do as many tests as possible. Generally, if the vital capacity is greater than 80% without any symptoms, you can be confident that you're okay. Once they start to develop symptoms, even with vital capacity of around 80%, they may have, particularly if the sniff nasal respiratory pressure is reduced, respiratory muscle weakness may need attention. And if the vital capacity generally falls below 50%, if you're not, if this isn't something that you do regularly, that's probably worth trying treatment. But a lot of my patients are health specialists, 50%, and they don't have any symptoms. We've heard about chronic issues, but so with those instances, if you see patients regularly, that maybe assess them activity, it might be worth going to be confident. But if you're down, it's less than 50%, sniff nasal respiratory pressure, generally it's around, around 50 to 60 centimeters for the nasal pressure is safe. Once they're below 50, and it's also important to see how temperature change rapidly. It might be worth intervening early because you may miss the opportunity for progression to the so the feel of the change as well. Initiating ventilation is now very ample evidence really that initiating ventilation is helpful in improving quality of life and life expectancy. There is lots of studies done on rodents. There are some studies on rodents, and this is actually being looked at in more detail, but I think sometimes there really isn't any convincing evidence to start so we're talking about 75% usually seems to be true, but I think it's worth studying, but I don't think there's a basis for it. These were all very important studies that we just included in my talk because there are still problems in various areas to treat people with neuromuscular disease. We often look at patients that could argue but actually the evidence is that the individual really does significantly their actual survival improves markedly. So there is a good case for starting with just a word of caution that carers need a lot of support when initiating non-invasive ventilation, and their ability to manage can affect the outcomes in patients. There are a number of other treatments that you will maybe come across in your literature search. Power Breathe is a device which is supposed to be an inspiratory muscle trainer, but actually it doesn't really have a place when you have respiratory muscle weakness, and that's because people with weak respiratory muscles are actually exercising their muscles all the time. Our muscles are more than adequate, so we don't actually have any difficulties. But patients with neuromuscular disease and respiratory muscle weakness, even normal activity is demanding for them. So they're training all the time. There's been some things on therapeutic acute intermittent hypoxia. I think that's far too early, and I'm not sure it's actually going to show anything. Palliative treatment always have to be remembered and always used in conjunction with non-invasive ventilation. So a handheld fan is very effective at making people feel less breathless. Once you've got them on non-invasive ventilation for daytime breathlessness, and oxygen is usually not required. Cough failure, you need a very good inspiration and strong expiratory muscles for a good cough, and you also need vocal cords to allow you to generate the pressure and snap open quickly to allow a massive cough. The ones just figures I'd like you to remember: if a person's cough gets down to 270 litres a minute, the flow, they're more prone to infections. And patients with a cough flow of 160 litres a minute, that's the minimum you need for successful decannulation of a tracheostomy. So those are just two figures that will give you some ideas of how weak your patient's cough is. The treatment is for cough. The first one I've dealt with is a cough assist. They look like a ventilator. It delivers a massive inspiratory pressure, allows the lung volumes to increase, and then as the patient coughs up, you flick it to a negative pressure, gives a suction effect, and it can improve cough flow significantly for all causes of weak cough. Inspiratory muscle weakness is expiratory muscle weakness and bulbar weakness. So it is a very effective treatment. There are cough is an attempt to try and get rid of secretions. If people can't get rid of secretions, they tend to build up, become thicker and stickier, and increases the cough load on people. So don't forget that you can actually loosen up the secretions with mucolytics, and there's a whole host of treatments available. Don't forget pineapple juice. It's actually very effective, and it's probably as effective as the oral mucolytics. Some medicines aren't compatible with it, but it's a very effective treatment. And you can humidify non-invasive ventilation. Chest oscillation is not, we don't use it in the community, but people who have had a build-up of sputum and then atelectasis, we do use cough. We might use this as an inpatient to help.
Dr. Mustafa?
Swallowing failure. The reason that we get swallowing failure is a lot of the times because we're respiratory physicians are looking after the patients and for their respiratory system, and the swallowing failure comes into play because of the cough weakness happening together. And I find that unless you deal with the swallowing failure in the respiratory clinic, it just builds up and no one pays attention to it because they don't see a gastroenterologist regularly. Because the swallowing is weak, they can't manage the saliva load that builds up. And that leads to lots of secretions. It's a horrible symptom. I find it very embarrassing.
Dr. Mustafa?
It causes dyspnea and dysarthria in its own right, an increased risk of aspiration, and why we get involved because it makes them hard to tolerate ventilation. Treatments are anticholinergics.
Dr. Mustafa?
You'll be aware of subcutaneous ones. You'll be aware of the oral ones and hyoscine patches. What is less well known is you can use atropine drops administered sublingually. Just remember to remind the patient is not to be put in their eyes. It's to put in their under their tongue, and it's a very effective way of dealing with saliva. And there are other medications as well, and I'd urge you to involve your palliative care team.
Excuse me, sir?
Mechanical devices we often use are like suction machines. And that can reduce the
Excuse me, sir.
tissues and towels. Radiotherapy and Botox are also effective. Botox is either very effective or not very good at all, so it's worth trying. But if it's not worked once, it's not likely to
Dr.
work.
Mustafa, we have almost...
And there are surgical interventions which I think are a bit drastic, and I've never actually had to use.
Excuse me, Dr. Mustafa.
I put in gastrostomy because we get asked if a patient's well enough for a gastrostomy, and if a person has vital capacity greater than 50%, sniff, nasal and respiratory pressure more than 40 centimetres of water, you can be confident that they can have a gastrostomy placed without ventilation cover. If it's if they're weaker than that, then they need to have a non-invasive ventilation present during the procedure. It can still be done, but there's a greater chance they'll need ventilation support.
Excuse me, sir.
So that's the main thing, that you obviously won't be doing the gastrostomy yourself.
Excuse me, sir.
But if they don't need support, then it's much easier to arrange.
Excuse me, sir. I'm very sorry, but we have run out of time.
I'm just going to last couple of slides now. This is what I give note to my junior doctors in clinic, and this is one of the things I just say to them to remember before when they actually see a patient in clinic for their sort of aid memoir. And it's just 6 S's. It's looking at, is a person short of breath? Do they have sleep disordered breathing? Are they able to clear their sputum clearance, swallowing problems, saliva? And here it's very important, can they actually use a ventilation? So just a few things in conclusion. Sorry, my last thing, sorry, I may have gone over a bit. It's subtle and insidious respiratory muscle weakness, causes cough impairment, and you need to make sure, are they able to have a peg placed? And remember, the respiratory muscle weakness can be treated, cough assist, and you may need to assist them during PEG, and please involve the palliative care team. Okay, thank you all very much.
Thank you so much, Dr. Mustafa. It was a privilege hearing your talk. Thank you for your time. We really appreciate it.